Now we move on to the next session, that is opportunities to assess and improve the organ quality in transplantation. As you all know, that the organ quality is very important before transplantation, because this will decide the short-term and the long-term outcome of the transplant. And also it is rather bit difficult to assess the organ before the transplant, and there are several methods by which we can do it, and this is the observation by the surgeon, the quality, there are several clinical scores, and histology as well as the molecular sort of things. And this is going to be discussed by Dr. Stephen Tullius, who is, and his biography has been given in the screen. Dr. Stephen, please go ahead with your deliberation.
Thank you very much, and thank you very much for this very kind invitation to India and this meeting. Appreciate the opportunity to talk to you. I'm going to talk about the opportunities of assessing and potentially improving the quality of organs for transplantation. As already mentioned, this is a very important aspect. Organ quality is determining outcomes, and it's also determining the immune response, at least in part, as the quality and the age of an organ is augmenting immunogenicity. I'm going to not only focus about deceased donor transplants, as they obviously have a reduced quality and potentially an augmented immunogenicity, but as living donor transplantation is particularly important in this country, I'm also going to be focusing on the quality and aspects of living donation prior to transplantation and how that affects outcome after living donation. Organ transplantation has been most successful, and it has been so successful in a way that to some extent it has been in the way of further progress to be made in the field. This is numbers that are shown to you here. Organ transplant volume in 2022 in the United States. And what you see here, that a record of 42,000 transplants have been done, 25,000 kidney transplants, and that has been an all-record high in the country. And at the same time, discard rates have increased. You see in the image on your right side that the discard rate continuously has increased. We now see about, for kidney transplants, up to 25% of organs not being utilized or discarded. And you see that that is a clear effect of age. What you see here up in the orange line is that the contribution of organ donors of older, and older is always relative, here over 55 years old, contributes with approximately 50% of those organs that are discarded, kidneys that are discarded for transplantation. And that results into the huge discrepancy between demand and supply. That is from a review article that we have published in the New England Journal a few years back. Yes, we have increased the overall transplants for kidneys. At the same time, in the United States, as globally, the amount of patients waiting for an organ transplant has increased. And the result of that is terrible. We see about 20 people dying each day on wait lists. We see the amount of patients on wait lists increasing, and that results to the consequences of this detrimental discrepancy between demand and supply, patients not being able to receive an organ transplant. So what are the opportunities that we have to meet this demand? Xenotransplantation is certainly an option. There has been a lot of effort and a lot of advancement in xenotransplantation during the recent and very recent years. Regenerative medicine is an opportunity, but I would still consider those opportunities as experimental. What I want to focus on is living donation. How can we increase and optimize living donation? And how can we increase and optimize deceased donor organ transplants? And both utilizing, for both opportunities, utilizing the armamentarium that we have to improve and to assess organs for transplantation. Now, I said that I'm going to have some focus on living donation, and that is very important because I consider the thoughtful and efficient and careful, detailed evaluation of donors critical. There are different ways that we can compare the outcomes of donors after transplantation. We can compare them to either healthy non-donors, we can compare them to the general population of non-donors, or we can compare the outcome in between donors, and with that do a very careful risk assessment of those donors that we advance for transplantation. And that results into center-specific thresholds being shown here out of the publication of the KDIGO guidelines. There are risk factors that we assess with the evaluation of an organ donor, and then the additional donation aspect that contributes to the additional risk that may then lead to the decline of a patient for organ donation. Again, that has to be very careful and has to be done very thoughtful to assure that the donor is safe and continues to live safely after the donation with one kidney. And the risk is not zero, as we all know. Donor assessment has to be comprehensive. It has to assess the kidney health risk on the one hand, the obvious surgical risk that we add with the donation, but also psychosocial risks and financial risks as they come down to the donor, and that all needs to be explained to the donor. The donor needs to make a thoughtful and very careful decision prior to moving ahead with donation. There is an increased cumulative risk, not only in the US population, but globally with kidney donation worldwide. And that risk is shown here, the risk that we develop end-stage organ disease as non-donors increases with age, and that risk is even further advanced post-donation. And that is very important in the advice that we give to donors, as a young donor obviously has a long lifetime ahead, and the increased risk will accumulate over a lifetime. But also for an old donor, it's critically important, as the old donor has also a significantly elevated risk post-donation. Now, what we are currently observing is a rapid increase of the older population. And that was for some time, particularly in the industrialized countries, but it's a global development, as you see here on this map, which shows you the proportional increase of older individuals over time. And what we see with that are obvious changes of aging that are organ-specific to some extent, and I'm showing you here on how that affects the kidney and what processes we see that are part of a physiological aging process, but also aspects that make older organs more vulnerable. What we see is an accumulation of senescent cells as one aspect, and I'm going to come back to that, as that is potentially a treatment option that we have particularly for older organs. But physiologically, we also see fewer nephrons, we see a decline in renal function, and we also see an increased vulnerability of older organs for the perioperative injuries that occur, with ischemia reperfusion injury being one example. Now, at the same time, we are using more older living donors as well for transplantation, and that is shown here on that slide, where you see that there is a proportionally augmented increase of older donors in the overall representation of living donors. If we compare the outcome of living donors compared to deceased donors, then we also see this age effect. And the comparison that you see here is adjusted to a standard donor, to a standard criteria deceased donor. And you see that the living donor below an age of 60, then up to 60, 64. But then once we cross this age barrier, has an outcome which may be inferior to a standard deceased donor transplant, but still superior to that to an extended criteria donor kidney. And what you see not only in this comparison, you also see here on the survival data that a living donor, even from an older donor, is superior in its graft survival and patient survival compared to standard, but not compared to an extended criteria donor, but not necessarily to a standard criteria donor. But what it shows us is that it is still advantageous to transplant a kidney or an organ from an older donor as well. Now, how do we assess the aspect of quality from a living donor? And there are criteria, there are scores that have been developed in accordance, in comparison to scores that we have for deceased donor transplants as well. This here is a living donor kidney profile index that lists several aspects that are important in the determination of the quality of a living donor for transplant, and age is here of particular relevance. And you see then if we apply this living donor profile index, that is then also reflected by the outcome here shown by the cumulative graft loss in accordance with this profile index. The important message here is that an assessment of that kind may allow us to improve the allocation of a living donor. We've talked about this during this meeting. Paired kidney exchange is allowing us to not only pair the optimal way of aligning ABO compatibility or HLA compatibility, but also aspects that we consider as critically important, that have been shown, that I've shown you before as part of the living donor kidney profile, that we match age, that we match the ideal composition of donor and recipient to optimize outcome. An important aspect then is to assess if a prolonged ischemic time in the context of living donation would affect outcomes. And this is shown here. The rate of delayed graft function is measured either in association with the age of the donor or with the prolongation of graft survival. And you see here that neither the prolonged ischemic time nor the age of the donor is significantly affecting the delayed graft function rate, or then in regard to the outcome in analysis of a death-censored graft failure as shown here on your right side. So we can use a paired kidney exchange approach to optimize the outcome of living donor transplants, not only for HLA and ABO incompatibility, but also to optimize other aspects of living donation. And that is what is shown here, that we may want to change our paradigm of approaching the paired kidney exchange way, that we don't only do this for the ways that we have traditionally used it, but also to optimize outcomes. Now, the obvious way on how we can improve the assessment and the quality of organ is through an assessment of an organ once it has been procured ex vivo. And organ perfusion and organ preservation provides us an opportunity for that. This is an image showing you the way that organs were perfused in the early days of transplantation. Those machines at the time were huge and they were very cumbersome to use, and that all has improved tremendously. Cold pulsatile perfusion has been introduced 15 years back. There have been ways, particularly lung transplantation, that we have approached to improve the quality and the assessment of an organ, and it has been shown for other organs as well, now with normothermic preservation for livers, for kidneys, in essence for all organs. And there is a huge potential that we have to improve quality and to assess the quality prior to transplanting an organ. We can even, and this is just an example that I provide you, combine this then with an algorithm that is based on artificial intelligence. We can collect the information that we get from the organ once it is perfused outside of the body, and with that, with the combination of all the parameters that we collect, a careful assessment can make a prediction on how this organ is going to work and how we can best allocate it. Donation after cardiac death for heart transplantation has been something that we did not think was possible, and this here on the right side shows you a New England Journal publication from this year where the outcomes of heart transplants that were assessed ex vivo after they have been procured are compared to the outcome of brain death donors, and you see how favorably this outcome for hearts from deceased donor organs whose heart stopped beating prior to procurement is. So really the potential is huge that we have with machine perfusion and with ex vivo opportunity to test organ prior to transplanting them. And those are the different ways that we have to do that. We can already start some of the treatment in the donor, we can then assess and treat an organ when it is perfused and potentially continue then the treatment post-transplantation. I want to give you one example of what we have done in the lab so far, but also tested it in discarded human kidneys, and that was a way to approach particular aspects of aging. I've shown you before that with aging we have an accumulation of senescent cells, and what you see here on your left, those red dots are senescent cells that we find in experimental system accumulating in different organs, skin, heart, and other organs. And those differences on the bar graphs that you see here, they are significant. So with age, we see a significant accumulation of senescent cells in organs that we use for transplantation. We don't only see this experimentally, those are data from clinical organ donors, where we also see an accumulation of those senescent cells. And what those senescent cells do is they shed mitochondrial DNA, which serves as a danger molecule and then increases the immunogenicity and augments the autoimmune response after transplantation. Now, there are ways that we can deplete senescent cells, and there are drugs that target those senescent cells. What makes those senescent cells characteristic is that they escape apoptotic mechanisms. The drugs that target senescent cells, senolytics, make it possible again that senescent cells undergo apoptosis and are then depleted. And if we apply senolytics, those drugs, in donor animals, as we have done it here, then you see that there is a significant reduction of senescent cells. Those red dots that you see in the old organs are not present to the same amount after the treatment with senescent cells. And if we take organs that have been treated with senolytics and then transplant them here in a mouse system, then you see that on the yellow line that you see here, that an old organ, after it has been depleted from those senescent cells, works as good or even a tiny bit better than that of a young organ. So that's very critical. That is very important that we have an opportunity to treat organs and particularly target age components that are of critical importance for organ quality and the immunogenicity of an organ. So in summary, I want to leave you with the thoughts of that a careful assessment of both live and deceased donor organ transplant is critical for the outcome after transplantation. I would want to submit that paired organ exchanges may offer novel opportunities to optimize outcomes beyond those that we have previously considered. Novel organ preservation and perfusion techniques have opened the door to assessing and improving organ quality, and that is an area where I'm convinced that we will have a great progress in the very near future. Organ aging is critical for the determination of quality, immunogenicity, and outcomes, and with the new approaches that we have, we may have an opportunity to improve the quality of an organ, to partly rejuvenate an organ, and to utilize those older organs for transplantation successfully. With that, I wanted to thank you again for the invitation and happy to take any question.
Thank you, Dr. Stephen, for an excellent deliberation. As you have rightly emphasized the old age and also the cold ischemia time, and they are rejuvenating the old cells. These are very new information for us. Can you please tell us more about the artificial intelligence in this area for assessing the organ sort of?
Yeah, so I think that will be a great opportunity that we develop systems and algorithms that will collect the information that we have clinically from a donor, but also with the opportunity of additional information that we can get through the preservation of an organ ex vivo, and then have this algorithm of data combined with an algorithm of the recipient that will then allow us to optimize the allocation of a particular organ to a recipient and optimize outcomes that way.
I believe that British people, they are coming out with this one sort of this artificial intelligence programming, and in very recent years, they will be introducing it. Dr. Hariharan, please.
Yeah, thank you very much. That was a wonderful talk. I want to make one comment about the organ discard rate in the United States. In my opinion, it's fairly controversial. If you are discarding a lot of organs, we would not have done 25,000 transplants. Increasingly, OPOs are able to harvest kidneys from older donors, which are not placed appropriately because of the regulations and the increasing cold ischemia time. And the transplant physicians and surgeons are reluctant to take organs which are more than cold ischemia time of 26 hours. So it's also kind of a newsworthy for the media. They catch on to this, that doctors are discarding organs. I think, if you really look at it carefully, transplant numbers have really gone up, and people are really careful about the quality of the organ to be transplanted. That's my opinion.
So what you're arguing is that we have artificially increased our discard rates because we are procuring organs that are unlikely to be taken.
Yeah.
It is possible that we have created some of this problem by ourselves. At the same time, I think we have a demand and a responsibility to go after every organ that is potentially transplantable.
Yeah. We can discuss offline. We have some newer data which is not published yet on this topic. It's a very important one.
I would love to.
Leave it for other.
Yeah. Thank you.
Stefan, congratulations. That's a beautiful talk, again, full of promise for us who are struggling to meet our patients' needs. I was wondering, what are the senolytics you use to deplete the cell? Is there an agent that is available for us today that we can apply clinically? There's monoclonal antibodies as a special depleting agents. Because I was very struck in your mouse model of DBAJ2 to C56BL6, they actually worked better in the older mice when you depleted it than even in the younger mice. The younger mice, the lines were almost superimposable. In the older mice, actually, you had a fantastic benefit there. So it'll open up extraordinarily well what we are dealing with the fact that 60 plus age is really responsible for much of the organ donation. The second question I have for you, you're probably already doing it. Are you measuring cell-free donor-derived mitochondrial DNA in the peripheral blood, and you're able to distinguish the recipient-derived mitochondrial DNA from donor-derived mitochondrial DNA?
So the first question in regard to the application of senolytics, there are current clinical trials in other areas going on with the senolytics, and yes, we could use, I think the opportunity is there to use senolytics in organ transplantation ex vivo and beyond as well. The second question was
The mitochondrial
the
DNA.
mitochondrial DNA. Did we distinguish donor versus recipient? No, we have not. We've measured the cell-free mitochondrial DNA, but did not distinguish between donor and recipient. We assume that it's mostly donor, but have not confirmed that.
Did you see more of circulating mitochondrial DNA in patients who have DGF versus patients who do not have DGF?
So experimentally, we see an increase of mitochondrial DNA with the prolongation of ischemia reperfusion injury, and yes, if we would see an increase of mitochondrial DNA in parallel to an augmented injury, yes.
Thank you. As a real compliment to you, I would like to ask you to share your slides with me.
Yeah, absolutely. Yeah.